So any points anyone would like to raise, either about John's presentation, Elizabeth's, or Dr. Bayen's? I think Laurent was first and then our colleague at the front. Thank you.
Well, thank you for this interesting presentation, the last about the pharmacist. I want to point out an issue that you have raised, and which I think is very important, the rapid changing way of practicing pharmacy or medicines through electronic softwares and things like that. We have an example of a label change that was implemented last year to prevent a medication error. And we had, again, issues of medication errors in a country to discover that in that country, the pharmacists no longer read, of course, any SPC, but they only rely on their software. So you need to be aware of that so that a change, an important change in the label to reach out really the people who need that information, you need to think really carefully to the chain, the supply chain, I would say, until it reaches really and these are new technologies and things like that. So we need also to be careful about that.
Important point, and keeping those systems up to date, really vitally important. Colleague at the front, thank you.
Okay. I was really pleased to hear that the pharmacist has this tool. I think it's brilliant. The impression I got, though, was that the information would be given as they were given the medication, rather than before the medication is made up. So I don't... Have I made that clear?
Yes. I think your question is it rather late in the process?
Yes.
But presumably, turning to John, the pharmacist could consult the software when they're first in receipt of the prescription. How would it work?
Can I just put another thing on top of that? I mean, that is great. What I would love to happen is that the person that makes the prescription out in the first place does this. But I had thought that this was probably an impossibility to make sure that every physician had a tool like the pharmacist. But if the pharmacists can do it, why can't the other medical professionals?
Good point. John, do you want to pick up the issue of at what stage in the process in the pharmacy the technology support on adverse reactions comes in?
Yes, it will vary from country to country, and not every dispensing process in European countries is exactly the same. It is, I have to be honest with you, it's more likely to be during the act of dispensing, but what you would see, I suspect, is that once you built this into the dispensing environment, if I can put it that way, then the pharmacist will become familiar with it, and they would use the dispensing support as a resource, and so then potentially when they got the prescription, if that was considered desirable and perhaps more effective, they could respond in that way. There's no reason why they shouldn't. Although the actual messaging part may be for example, as is in Belgium when they scan the pack. Going back to the point that the gentleman made earlier, if various developments at European level come to fruition over the next 3 years, it's likely that most prescription medicines at least will be serialized and most pharmacists will be scanning. And then you'll have an opportunity to realize the kind of messaging systems that we've seen. You'll also see, I think, within a decade, e-prescription virtually everywhere, given the efficiencies which are demonstrated when e-prescription has been implemented. One final point, you do see prescribing tools for doctors in some European countries too. I understand that, I'm not really a UK expert anymore, that there is one in the UK, but doctors often say that they're pressurized, they only have a limited amount of time, they give priority to other things rather than looking at the software. So that's where I go back to this point, in every forum I speak, pharmacists and doctors working together is 1 and 1 plus 3 equals 3. Not 1 and 1 plus 3, but you know, my mathematics.
Very good. Well, I hope perhaps even the WebAE project will enable some of these technologies to be scrutinised for their utility. Thank you. Professor Bayens, and then we'll come to Gro.
I agree, the very important role of the pharmacist. But for my patients, geriatric patients, only 10% reach the pharmacy. 90% never see the pharmacist.
Okay, so it's a type of challenge for the new world we're in. Gro, thank you.
Oh, like that. So, Gro Lai representing EBE and from Novo Nordisk. A few comments. One of them is the reporting, adverse drug reaction reporting in Denmark, there's another important thing of the system is that it's no longer allowed for a company, a pharmaceutical company, to request follow-up questions of the physician. And that's because, of course, we are afraid that some inspectors may not be equally pragmatic. So we do a lot of follow-up questions, and they got very annoyed and overburdened. And they said, no, we will only accept questions given to us by the agency. And I don't know how much it helps, because we still now provide all our questions to, of course, the agency. So I was wondering whether patients and physicians would somehow think about how they can get a focus on the reactions they actually intend to report and are maybe even concerned about, as opposed to everything that we hear about, the hypoglycemia that was not a surprise and so on. So that was one comment. And the other comment was to the physician, because in Denmark, we again have a wonderful system. So the GP of the patient can see in his IT system what has been provided to that patient, and I guess a specialist can as well. At the hospitals, it's not possible, and the problem is data privacy. Because if you're not treated by one physician, but by a whole hospital, then they think everybody can know. So really, data privacy is also there, a big issue.
You've given us a further dimension on the Danish model, which has obviously been very useful in some respects, but you've got some helpful insight there. Any of our colleagues who've made presentations want to pick up the points that Gro has made? I think the Danish model is going to need further exploration, so please consider yourself a resource. Thank you. Wim.
Bit busy. I would like to ask in general, and it is difficult now because a lot of people are disappeared already, but patient organizations and other organizations, I know they do have the obligation when they are here in such a meeting to report very carefully to their own organization. But there are now very big industries, of course, now from the legislation, from the pharmaceutical side. I would like to ask, when you are asking to everybody that, and you will give a good summary, press release or something like that. It's not that we have all to do it with our own remarks. Now, just 1 or 2 pages, and June, you are always summarizing in so strong words, and then everybody is optimistic and saying, yes, okay, let's go that way. So I would urge to everybody from the healthcare professionals, from the patients' organizations, from the industries to do that.
Wim, that's a really constructive point, and I think it takes us in our closing minutes to think about what we've distilled today and what next. I think what you're saying is all our stakeholder colleagues in the forum today will be going back to their constituencies and will wish to give feedback in varying degrees. It's been a really rich discussion. There's been a lot of comments. Our first objective today was to hear the perspectives of all the stakeholders, to fully understand them. And I'm sure everyone will agree that we have more than achieved that. And not only have we had some very honest and constructive input, we've had ideas and suggestions that need to be thought about quite carefully as to how they fit into the plans, should the plans that I think EMA colleagues set out so clearly be adjusted in any way. We set ourselves the objective to refresh on priorities. And again, I think we've understood, I think many of us are familiar with the stepwise implementation, the prioritised implementation. There are legal requirements that are still to be realised in reality. But we've also heard about some fixes, quick wins, if you like, and ideas around best practice, optimal use of tools. So we need to capture those. I think the third big question was how we continue to collaborate and to have communications. We've heard that it might not be a one-size-fits-all, like this occasion, it might be a topic-specific collaboration, which could be as short or as long or as repeated as it's needed to be. And I suspect that colleagues in EMA will want to think a bit about the menu of collaborative options going forward. So not a quick and easy answer, but I think your request for something that can be taken home over the next fortnight or so would be a very reasonable one. I think we've all said that public health in the EU is being better protected as a result of the legislation because of the focus that EMA has set on delivering public health protection. I think we can all see that transparency is better than it was. We can see that, and the timeliness of information is much better. We know that. But I think where we have to accept that a lot needs to be done and a lot of focus needs to be placed is simplification or better regulation, call it what you will. I think that really has to be over the coming weeks and months in everyone's mind. So I think those were my take-home messages. They may not be as specific as you were hoping for, Vim, but I think there's been such a richness of contribution that a simple shopping list wouldn't really be the right thing for everyone here. While I've been talking away, I don't know if Fergus would like to say anything at all from the EMA perspective. I think the one phrase is thank you that I would like to say. A lot of people have given a lot of effort, time, and really careful thought to bring us together today with some really helpful thoughts and ideas. So my finishing words are thank you. Thank you very much indeed.
Thank you, June, and thank you to all of you, both speakers, agency and stakeholders on the panel, to our team here who've supported the meeting, and all the teams at the agency, the national agencies, in the companies and other associations who've been working together, because I think we've seen today that we have brought an awful lot of things forward over the last 2 years. There's some more to do, some technical tools still to deliver, but I think one of the key things now is to sit together, cooperate, and learn how we can help each other. Some things are large technical issues, some we've learned are quite small. So we will go away and, as June says, find the opportunities and fora which are fit to purpose for the different issues. And really, I think one of the key things is learning to understand each other, learning to listen and to find out the real needs. And in that, I think at the end of the day, we've heard from healthcare providers, but particularly from the patients. And there are clearly many different situations, many different patients, whether it's young, elderly, different kinds of condition, different social circumstances, whether people are away from the doctor and the pharmacist in the countryside or in a hospital. We need to ensure that they can understand, that they can get the information fit to their circumstances, but also that we collect the information that enables us to protect a very heterogeneous group of people, each with their own needs and expectations. So let's keep on the communication so that we can fulfill that public health objective for the interests of each individual situation. So thank you all very, very much, and have a good weekend, have a good trip home, and we'll see you all again in perhaps different fora, in different groups, but also together, because I think this overview periodically is a good way of recapping and setting the scene for the next set of detailed actions. Thank you very much.